Obviously, I'm really glad that everyone is home safe and sound on this messy day. Before I introduce our guest speaker, I want to attend to just a couple of housekeeping and general instructions. This is kind of redundant because you guys have already done it, but please keep your microphones muted unless you have a question or we open up the session for discussion. Also, please use the chat box as much as you would like. Derek and I will be attending to the chat window, and we can funnel any of the questions or the comments that you have directly to Joe. If you have any difficulties during the session, I sent out my cell phone number so that you all can text me and just let me know if something is going wrong on your end. Just for your quick access, my number is 201-978-3351. It's also in the news and announcements that I sent out this morning. The other thing is that this is an abbreviated class today. We're going to hear from our speaker and then offer time for questions and answers. So we're planning for about 2 hours max. Although school is closed, we didn't want to attempt to make up a class in May or potentially lose the chance of hearing from our scheduled speaker. So I'm really appreciative that you all were able to join us today on the web session. So with that said, I'm so pleased and so honored to welcome our guest lecturer for today, Joe Young. Joe is the Executive Director of Disability Rights New Jersey, and he's been instrumental in advancing the rights of people with disabilities and advocating for statewide change regarding the policies and procedures that govern the delivery of community-based services in our state. I personally had the privilege of taking a mental health and the law course taught by Joe, gosh, I guess it was over a decade ago. And I can say that from that experience, my eyes were certainly opened. We may not oftentimes reflect on how legislation and court rulings influence the rights of people with disabilities or just the mental health system as a whole. But understanding the historical precedents that have been set is really critical to being advocates, which is a big part of our job in psych rehab. So today, Joe is going to be discussing the changes in funding mechanisms for behavioral health care coverage, the ACA, the Affordable Care Act, and its implications for behavioral health care, the integration of physical and mental health care, and the potential repeal and replace of the ACA under the new administration. So talk about timely. I don't think we could have had a better time to have Joe with us, even if he just reflects and gives his thoughts on what could possibly happen. So with all of that said, I'm going to turn everything over to Joe. Thank you so much for being with us today, Joe, and I'm really excited to hear from you.
Thank you, Amy. I appreciate the invitation. Although this is not one of my favorite subjects, my head starts hurting as soon as we start talking about healthcare and Medicaid and things like that. So I'll do my best. I think the original title was the ACA and managed care, but in looking at there's no good way to do a title for healthcare these days, because you start talking about one thing and everything else it grows off of it, and it's like an octopus and several octopi. It just keeps growing and growing. So reluctantly, I picked this healthcare and behavioral healthcare. It's just a brief overview of some of the current issues that are out there and a little bit of what may be happening in New Jersey. Please feel free to ask questions, however the best way to do it, because it can get complicated very quickly. And sometimes we slough over things that we think we know and don't, or other people may get lost. So we'll do our best. Next slide, please, Darren.
Okay, just so you know, Joe, in the lower left corner, you should see like 2 arrows. You see that? If you use your mouse.
I got a mute button and a stop video button. That's about it at the moment.
Okay.
Down here? All right. That's hidden by my thing. All right. I got it.
Great.
But it's not.
Not working? Okay, I can do it.
All right. So I guess the first thing to look at is, how are people insured in the United States? Because how you're insured makes the difference about the type of insurance, that makes the difference about your access to services, and a variety of other things. So this is from 2015. That's the latest information that's available. Now, if you're going to add up these numbers, you're going to find out that it's over 100% because some people have more than one type of coverage. But first off, people who purchase insurance directly with the healthcare provider is about 16% of the population. Most people, the vast majority of people in the United States, get their health insurance through their employer. And my number over there is covered, but I think it's like 55% of the population gets health insurance through their employer. Medicaid is the next largest one at 19% of the population. Medicare at 16%. Military covers 4%. And there's still 9% uninsured. Now, this number was closer to 20% a while back, and it's been slowly decreasing. So, again, when we talk about insurance coverage, knowing what kind of insurance we're talking about is very important and sets the discussion. Yeah, I don't have the arrows anymore at all.
No problem.
All right. So in addition to the type of coverage that somebody may have, there are different payment models. So although somebody has employee-sponsored insurance, they may have one of these three or even a different kind of payment model. So fee-for-service is generally pretty much it's the standard for Medicaid, Medicare, but even that's changing. So fee-for-service means you go into the doctor's office, you get some kind of service, or if you look at the doctor's bill, 6 or 7 or 10 services. The doctor bills the insurer for each one of those services based on the rate that the doctor, the healthcare provider, has negotiated with the insurance company, and then you walk out the door, right? So you may also, depending on whether you have Medicaid, Medicare, private plan, you may have, if it's Medicaid, there's no deductible. Generally, there's no other payment. In New Jersey, there's no other payment needed if you have Medicaid. Medicare has deductibles and copays. Private insurance generally has deductibles and copays. So the person, depending on the type of insurance they have, may contribute to the cost, but the cost to the reimbursement to the medical provider is based on the volume of service that particular provider provides. So if we're looking at encouraging people to get health care, the fee-for-service model, basically, the doctor or the healthcare provider isn't going to kick people out because they're not getting paid. They're getting paid for every service that they're rendering. Now, they may not be getting paid the amount of money they want, or the amount of money they think is necessary, but they get paid based on volume. So there's no disincentive to seeing somebody unless that particular person uses up 30 minutes of time, or the equivalent of 30 minutes of time, and the doctor's only getting paid for the equivalent of 15 minutes. So doctors on a fee-for-service model may be reluctant to see the more difficult patient because they may not be reimbursed sufficiently for seeing that particular person. A managed care model is significantly different. Usually managed care is based on a capitated rate. So in other words, a physician or provider, healthcare provider who's working in a managed care system generally gets so much money per month per person on their rolls. So if you've ever participated in a managed care system, you're generally asked to pick your primary care provider. And sometimes the first time people, you go on a screen and the first time you've ever seen a doctor's name, but you pick that doctor because it's in the area, you're now on their rolls. So generally most systems, whether you see that doctor or not, that doctor's getting paid so much per month because you have picked them as the primary care provider. And that doctor, then generally you can't go to another doctor without going to that doctor first. All right. So that doctor is screening out your needs, your access to specialists generally, and that's what he's getting paid in part the per capitated rate for. So in this kind of system, the insurance company makes money if it denies services, if it holds back or limits services, because in this system you get a premium and then the insurance company pays it out based on services that people ask for, but it manages the service. So it can say, I don't think you need 10 sessions of this, you only need 5. And then the 5 not paid may go to their bottom line. So in this kind of system, generally speaking, this kind of system, there's a disincentive to provide a full array of services and more of a incentive for the for-profit or nonprofit company to provide ration service. Value-based reimbursement is the newest thing on the block. That's what everybody is talking about these days. It's still very difficult to figure out. There are probably hundreds of grants floating around in the country right now from providers and governments and insurance companies, all these kind of people, trying to figure out a good value-based reimbursement system. So in this kind of system, it's also kind of a per capitated rate. Some may be a fee-for-service rate, but generally there are incentives or disincentives based on the outcomes for health services, right? So if one of the value-based reimbursement systems is a Medicare disincentive system, where hospitals are penalized if somebody goes back to the hospital for the same diagnosis that they were discharged from the hospital within, say, the last 30 days. So if somebody goes to the hospital with a respiratory ailment, is discharged, and then is readmitted to that hospital within 30 days with the same diagnosis, then there may be a disincentive that the Medicare may come back and say, you owe us money because there are too many of these incidents. There are other value-based systems which are incentive-based, positive incentive-based. So it looks at if, in fact, the people on your roll that are in your panel or in your group, if there is a decrease in admissions for this population this year over last year, and that actually results in a savings in money, then the money that generally in this case Medicare or Medicaid has saved will be split among the people that are in in this case it would be an accountable care organization. Or the individual provider may get an incentive depending on the program, that the fact that their readmissions were less. So this value-based reimbursement system appears to encourage health outcomes rather than volume, rather than rationing care. It appears to incentivize good outcomes for individuals. The disincentive is you don't want too many sick people in your group, or it's going to drive up the cost. So if your group is composed of nothing but people with dual diagnosis, mental health and substance abuse, or mental health and developmental disabilities and substance abuse, you're not going to want that mix because that's going to be a very expensive group of people to deal with. All right?
Question, Joe.
Yes.
Does anybody use this right now, value-based reimbursement?
Yeah, there are a lot of programs. So there are things called accountable care organizations, which was part of the the Affordable Care Act. Medicaid is encouraged by Medicaid for accountable, so you could voluntarily form an accountable care organization. So my primary care physician at the moment does belong to an accountable care organization, which I think is 200 some odd doctors affiliated with a local hospital. So they basically are becoming the insurance company. So the actual person that's paying is Medicare or Medicaid. And they're forming their alliance as an insurance company, and they have incentives. So their costs, a really simplified example would be that their cost to Medicaid in the previous year was $20 million. So if they meet some outcome measures based on some benchmarks, lower rehospitalization, fewer people, more people whose diabetes becomes under control, that kind of thing, and they save $2 million to Medicaid, then they may share some portion of that $2 million savings amongst themselves. All right? So that's one form of value-based payment. The disincentive that I talked about with Medicaid is another one. So they're floating out there at the moment. They're still kind of like pilot projects, but that seems to be the wave of the future because nobody likes the other two for the reasons I said. But obviously the problem is, so there was in New Jersey, and I'm not going to remember the name of it because, again, my head starts hurting and these things get complicated. There was a pilot program for, I think, some behavioral health accountable care organizations. And they had an incentive over 2 years that if they saved money, they would be able to share in the profits. No one saved any money. So there was no profit sharing for that particular program. So it was there as a tool. But as I said, if you're going to have in your group the most difficult people to provide services to, the value-based reimbursement system is going to be very difficult. All right. If you're going to deal with an inner city, low-income group of population, you're going to have a lot of illness because poverty and illness are inextricably linked. Suburban area where lots of services are available, then a value-based system may in fact work. All right?
Yeah, great.
All right, so despite everything, despite all the plans, despite all the changes, despite the fact that more and more people were being insured than they were being insured before, part of the reason for the Affordable Care Act was to look at the increasing costs of health insurance and medical care, and the fact there was a persistent number of people who were uninsured. So the Affordable Care Act, which I trust most people know is Obamacare, because apparently some percentage of the population thinks Obamacare and the Affordable Care Act are two different things. So I'm going to use the Affordable Care Act just to make it easier. So it was designed to do things. Two things. Is one, to try to decrease the increasing cost of health insurance and medical care, and two, to tackle the number of people who are walking around without insurance. So the second one, there's been a big step. So it's really cut the number of people. A lot more people are insured now, have health insurance now than they were insured before. But healthcare costs and health insurance costs keep rising. Now, some of that's due to the fact that Congress had promised as part of the Affordable Care Act to pick up some of the losses that the insurance companies may have experienced in the first couple of years. And then surprisingly, when it came to it, they didn't fund what they had promised to fund. So that drove the insurance premiums up the last couple of years. But the question is, is anybody ever going to be able to resolve these problems? And what's being done now to try to take a look. All right, so if we look at the major provisions of the Affordable Care Act, the ones that aren't incredibly technical, the major things then, and if you look at how these affect people with behavioral health issues, and when I use behavioral health, I assume I'm using it to mean both mental health issues and substance abuse, because apparently, again, there are multiple different understandings of what behavioral health means, but that's my use today. So if you look at how these changes affect people with behavioral health issues and substance abuse, they can be fairly significant. So then one of the big things that everybody knows about the Affordable Care Act, and apparently everybody likes about the Affordable Care Act, is the ending of the pre-existing condition problem. So under the Affordable Care Act, insurance which is sold on the marketplace, and also those insurances which go through the employer plans, can no longer deny somebody access to those insurance because they currently have an illness or they had an illness in the past. So that's the pre-existing requirement. And before the Affordable Care Act, it was incredibly difficult for people with disabilities, pre-existing conditions of any kind, to get insurance at a reasonable cost. When we were...
Question about that.
Yes, go ahead.
I always wondered this. So I understand that they have to basically offer you a policy, but can't they effectively limit how many people would actually take those policies by just making them very, very costly?
Well, that's what they were doing before. So if you had a pre-existing condition, usually you had to have a 6-month wait, but when you got it, the cost was very, very high. All right. So the difference in the Affordable Care Act is that you can't use that person's prior history to rate the cost of their insurance.
Oh, okay, I see.
Yeah.
That makes sense.
Right. And the offset for that, so that now seems like a problem. So now we have all these people, so we know the biggest indicator of people using the system in the future is people who used the system in the past. the problem with that then is, so how do you keep the system affordable? Well, you do that by making everybody get insurance. All right. So if you make everybody pay into the system, so it's just not sick people in the system. If everybody is paying into the system, then you have more money available. So if you jump down to the individual mandate, that's why there was an individual mandate, because you're not going to be able to fund a health insurance system if only sick people are in the system. All right. So you have to have well people in the system. So that's why the mechanism here was to require individuals to get health insurance. And if you didn't have health insurance, you're going to pay a tax. Now, there are complex, arcane legal reasons why they're calling it a tax as opposed to a mandate. Government probably can't order you to get insurance, particularly the federal government. That's probably not within their powers of Congress to order people to get health insurance, but they can tax people who don't have health insurance based on the fact that they're costing other people, the system, money. Or at least the Supreme Court agreed that calling it a tax was okay. If they would have called it something else, it may have run into a problem. So for our very legal, arcane reasons, it's a tax. But that having everybody in the system is what's going to pay for the system for these other benefits. All right.
Joe, I have a question.
That sounds like Carlos.
It is.
Hi there.
Hi, how you doing?
Okay.
I'm interested in uncompensated care. If prior to this, if somebody went into the hospital and needed, major, let's say, coronary surgery and didn't have insurance,
right?
Do the laws require the hospital or somebody to provide that?
In New Jersey, yes. All right, and so that's when we get to the repeal and replace system, and that's why you'll see. I think it was an op-ed from Betsy Ryan yesterday in the Spotlight article about concerned about repealing and replacing Obamacare, because if they go back and take some of these people who didn't have insurance, who now have insurance and have no insurance again, then the hospitals are going to pick up the cost. So New Jersey has generally had an obligation that hospitals cannot turn away people. New Jersey, and the government then compensated the hospitals for that whole charity care thing we were talking about. We talked about for years about charity care in New Jersey. Right.
But that's just a New Jersey law. Okay.
That's just right. Other states, it's, go.
Okay.
Good luck.
Yeah. Okay. That's the part I didn't get. Thank you.
Right. Yeah. So there was, and the problem with charity care in New Jersey was that the hospitals were only reimbursed at a fraction of what they were actually spending. So that's why this is a really big deal for the hospitals and healthcare providers. The fact that people are insured. And Jersey has in fact cut back its charity care significantly since the institution of the Affordable Care Act. The other thing that's important, particularly for our population, is this idea of essential health benefits. And I think I got a slide later on about what the essential health benefits are. But in the past, I think the numbers, I don't have it handy at the moment, I think the number was that only about 60% of health insurance plans that people got through employers included behavioral health coverage. All right. So a large minority, but a very significant number of people who had health insurance had no coverage for behavioral health and even less for substance abuse. So it was very rare to have substance abuse coverage and coverage for behavioral health. And we'll see, I think, on the next page, and even an important thing is the parity issue. But at the very least, the essential health benefits was it mandated that behavioral health coverage be included as an essential health benefit. So there can't be an insurance plan now that's required by the Act that goes out without covering behavioral health services. The other big one that everybody likes is that children can remain on their parents' policy until age 26. Those of us whose kids became 26 before this was passed know the difficulty of trying to maintain coverage sometimes and making sure the kids have adequate amounts. The individual mandate we talked about. The health insurance exchanges, so the exchanges are always the controversial thing, how many people are on the exchange, how many aren't on the exchange. But the advantage of the exchange is, in addition to having information in one place, it came with navigators. It came with people who helped other people find services, evaluate the health plans that were available, and assist them to pick the plan that they wanted. Part of, when we get to the other part of repeal and replace, is to make more private health plans available, make more plans available through the private market. And I don't know about you, but again, picking a healthcare plan or an automobile insurance plan or any kind of insurance plan becomes incredibly complex. And the less sophistication you have, the more and more difficult it gets. So there have been some options for people with mental health, people with chronic illnesses, to opt into a variety of different kinds of plans with some incentive-based, performance-based plans that I was talking about before, some behavioral health kinds of things. And they were lured into the plan because they got a pair of free reading glasses, or maybe a sticker at the Walmart when they went to go there. That's not the way to choose a healthcare plan. So the advantage of the exchange was it provided that kind of technical information. All right. In addition, the low income subsidy. So this is if you're going to require everybody to get health insurance, then we know a lot of people aren't going to have it, aren't going to be able to afford it. So the subsidies, so providing subsidies to people to allow them, to help them to pay for insurance, is a really big part of the plan. So depending on the amount of income, and apparently the affordable healthcare computers are hooked up with the IRS computers, so they'll immediately know what your income is from the year before, and based on that, there's a subsidy. So for individuals with income up to 400% of the federal poverty level, they're eligible to get a subsidy to help them pay for what already should be reduced costs through the exchange. Now, probably the most important thing for our population is the Medicaid expansion. So already people with mental illness are generally on Medicaid. I think it's 62% of people on Medicaid have a mental health diagnosis of one kind or another, and almost everybody who needs mental health insurance is probably receiving some form of Medicaid, but not everybody necessarily has a diagnosis just because they don't have services or can't access services. So the Medicaid expansion, which pulled in a whole lot of individuals who were just poor, and again, poverty and healthcare needs are inextricably linked. So pulled in this population who were poor and gave them insurance coverage. Now, this was the one part of the act that the Supreme Court did not go along with. Again, arcane legal reasons. But the Supreme Court said that the federal government could not require the states to spend money for this particular program. Now, the states weren't going to spend money for 5 years, but the federal government ruled that this would be a state option. So the state had the option of deciding whether or not to participate in the Medicaid expansion. So again, I think it's 38 states, including New Jersey. The ones who don't participate all have Republican governors and legislatures, and people there who are poor and can't establish a disability, again, do not have health insurance through Medicare. Again, it's one of those, they're going to have to rely on charity care to the extent it may exist in those states. And then there's this whole payment reform thing. Some of the things that the government did said, fine, we have to control rates, so we're going to stop paying doctors some money for some services. There's a move towards bundled rates. So instead of getting $5 for talking, again, totally hypothetical, exaggerated examples, but $5 for talking to the person, $5 for looking in the ear, $5 for looking in the nose, $5 for looking down the throat, and $15 for giving you the flu shot. We'll give you a bundled rate. So if you have an illness, you have a flu illness, we're going to give you this rate for flu. And then the value-based reimbursement stuff I talked about before, which again are mainly pilot programs, demonstration programs. And Jersey's got a couple of them going. There's one that the new one's opening up for CCBHC. Don't even ask me to guess what those initials are. There's a behavioral health in there. So it's
Joe, it's community care behavioral health.
All right, thank you. So it's a capitated rate. It's a consortium of individuals. It's for dual diagnosed substance abuse and mental illness. And there's a list of required services and optional required services that the provider itself must provide, optional services that it can affiliate out with. But again, it's intended to provide a coordinated care among providers. That's a capitated rate. So everybody gets so the provider gets so much per person if at least one of those services is provided a month. So if there's a month where that person doesn't get any services, no one in that consortium gets the capitated rate for that particular person that month. That's just another way of looking at reforming rates and encouraging coordination of services in that particular case. And there, thank you. So these are essential health benefits. So again, a lot of these people were not able to get services or some of these services in. So every healthcare insurance must include ambulatory care services, walking into the doctor's office, emergency services, hospitalization, pregnancy, maternity, newborn care, prescription drugs. A lot of general insurance companies did not have prescription drug coverage. So you could go to your doctor, you could get a prescription, but then you couldn't buy the drugs. And surprisingly, that didn't result in good healthcare outcomes. Rehabilitation and habilitative services and devices, so our assistive technology devices, the wheelchairs, for things like that, lab services. So preventive and wellness services is one of the really big deals in Affordable Care Act that most people seem to like. So if you go to the doctor these days and you have insurance, you shouldn't be paying for your flu shot. That's preventative care. You shouldn't be paying for your annual exam. We have a very big argument occasionally because people keep getting billed for mammograms. Mammograms are preventive care. They should not be billed. You should not be getting billed for that if you have a covered insurance under the Affordable Care Act. Now, again, I went in that list in the beginning, so not everybody has that. If you're a self-insurer, then maybe you don't have to provide all those services because our insurance, the way we regulate insurances, is really screwed up. Next slide, please. All right, so here we get to the important stuff for us. Mental health and behavioral health services is a required essential benefit. So all plans must cover behavioral health treatment, such as psychotherapy and counseling, mental and behavioral health inpatient services, and substance abuse disorders. So there must be something in the plan that covers those services. How rich the plan is depends on a variety of things. It depends on, in fact, probably how much you're paying for the plan, right? But what you're paying for mental health and behavioral health services can't be any less a benefit than what you get for medical services, all right? So in the old days, it used to be fine. If you have a broken leg, then you get 30 hours of rehabilitation services for the broken leg. If you had a mental health illness diagnosis episode, then you only got 15 hours or 5 hours of services. That's gone. The caps, you can only spend $100,000 on mental illness this year, but you can have an unlimited amount on medical health services. Those are gone. You cannot, in the definition of coverages, discriminate against mental health coverage, substance abuse coverage, and medical coverage. You're also not supposed to do other things. So you're not supposed to make it harder to access mental health services. So you shouldn't have to have some other extra assessment that's necessary to access mental health services. It shouldn't be more difficult to access. It shouldn't be like you can only get it on Tuesdays where all other services are available on Monday, Tuesday, and Wednesdays. So the treatment of mental health services and physical health services is supposed to be the same in your plan. There can't be a discrimination between the two where behavioral health services loses out. And that's a very significant difference and a very big improvement for the people with mental illness and substance abuse. But, so let me tell you this, it's complicated. John Jacoby at Seton Hall Law School has been running a project on mental health parity for the last 2 or 3 years. He's done 2 conferences. I went to the last conference. I understood about 10% of what they were talking about. when you get down to the weeds of how to ensure that people have mental health parity in a health insurance program, it gets incredibly complicated. So as I said, so most of this I talked about before, pre-existing conditions, so that the ACA and behavioral health, so underwriting rules allowed individuals who receive mental health services who were not able to get them before are now able to get them at a reasonable cost. Only 54% of individual health plans covered substance abuse and 61 mental health care. 18% didn't cover prescription costs at all. Now we're still going to have a plan with formularies and medication. That's one way insurance plans are covering costs these days. So you have to have medication that will treat a diagnosis, but you don't have to have all the medications that treat a diagnosis. So for example, again, somewhat hypothetical, you'd say the diagnosis is schizophrenia. So generally it's okay if a health plan has one prescription in their formulary that will provide treatment for schizophrenia. Generally, we know that the medications don't work the same for everybody, that some people with schizophrenia don't respond will respond to one and not respond to another medication. So this becomes a problem then when picking a healthcare plan or a managed care plan through the exchange, or if you're on Medicaid, Medicaid is managed care in New Jersey, ensuring that the plan that you're on has the prescriptions that you have. And generally the formularies have covered generics, but not the more expensive, newer treatments. Parity, we talked about that there should not be limits now on people receiving, the people getting mental health services should be the same as people receiving healthcare services. So everybody confused? Yeah. Preventive care. So one of the advantages of things in preventive care is that preventive care on the ACA includes depression and alcohol screening. So my doctor, who's in the Accountable Care Organization, I could tell when he joined because he asked me a question about depression. That's it. That was his screening of depression. It was asking me a question about, I don't feel depressed, do I? Was his idea of mental health, of a mental health screen. And then he did ask some questions about how much alcohol I drink. So that was a new routine for me in visiting my primary care physician. Part of that is due to the, I'm sure that his depression screening is much better for other people, but.
So Joe, let me interrupt you for 1 second. It's Amy.
Sure.
So asking those two kind of really generic questions as part of your physical exam, is it your impression that if there was anything indicative that you might in fact have some symptoms of depression or are self-reporting that you drink too much, some follow-up assessment would be done at that point?
Yeah, so again, it depends on the system that you're in. I think we're going to try to get into the integrated care in a bit. I think in general, so these guys are all in an accountable care organization affiliated with the hospital. So my guess is if I would have answered a question about feeling really depressed about something, or I've been very unhappy since my wife died, that she didn't die, she's upstairs, but those kinds of questions, I suspect I would have gotten a referral to somebody else in that accountable care organization. And obviously we know most times referrals are not followed up on.
Yeah.
Right. So there's a difference between referrals and integrated care. So my guess is for the general accountable care organizations and for these kinds of screenings that you're getting when you walk into the MediMerge clinic, there's not a whole lot of follow-up on those. And my doctor is a solo practitioner, so he doesn't have a social worker that's available to follow up with anybody on anything. Mm-hmm. Hopefully when you get into the practices that are affiliated with teaching hospitals and stuff like that, you get a whole different array of services. Yeah, but for the most part, my guess is that you're trying to get maybe you should talk to this kind of person kind of thing.
Okay, thanks.
So right. Joe, the term preventive care is a bit of a misnomer then, right?
Yes.
Okay, because I always get confused. When you think of preventive care for serious mental illness, it's like, what the heck does that mean? But
Yeah. So when they're talking about preventive care, 99 times out of 100, they're talking about a medical thing, and they're talking about things that everybody knows about. So preventive, under the ACA, you cannot charge a patient for preventive care. All right. So that's annual screenings, flu shots, mammograms, and the screening stuff. So that's not a whole big set of stuff.
Mhm.
So it's not like earlier intervention services for people with mental illness, which we still have a problem with in Jersey. But yeah, so it's and some plans have more generous stuff about preventive care. So you may belong to a employee-sponsored plan, which if you go to the gym and record that you have gone, 5 times in the month, then you get a gift card from Amazon as a result. That's what some people consider a preventive care plan.
That sounds like a real preventive care plan.
That's right.
The other stuff sounds just like early screening plans.
Right.
Okay.
Right. And
Thanks.
but this has also run into some problems because some employers, for every solution, there's going to be a problem. So some employers, in order to keep down insurance costs, have been requiring employees to participate in their preventive care plans.
Mm-hmm.
So for some people who may be smokers or some people who may be obese, they're required under their plan, or the employer is trying to attempt to require them under their plan, to do preventive stuff, to engage in exercise, to engage in smoking cessation programs and stuff like that. And if they don't, then the employer's share of the healthcare costs go down and the employee's costs go up. So some of that's being litigated at the moment.
Interesting.
As to whether or not that can be done, or all kinds of free speech and issues and things like that. So I have no idea where that's going to turn out. The Affordable Care Act has provided a whole chunk of additional insurance for young adults. That's that under age 26 thing. So people between the age of 18 and 26, where a goodly number of mental health diagnoses emerge, can generally remain coverage under that time. And then Medicaid expansion, which we talked about. Even before the ACA, Medicaid was covering more behavioral health treatment than anybody else. Since then, it tends to be more and more. And Medicaid benefits are more comprehensive than private plans. So in Jersey is a difficult place for people with behavioral health service needs because of the problem with psychiatrists. So half of psychiatrists in New Jersey do not participate in Medicaid or Medicare, or even a goodly number don't participate in private plans. So you can't get to see a psychiatrist unless you can pay their private rates. If you have Medicaid, you probably have access to a psychiatrist, but there may be long waiting lists to get to them. Because again, the rates are low, so there's not a large number. But there aren't a large number of psychiatrists generally across the United States anymore. It's one of the fewest picked specialties in med school. I don't know if that has traditionally been the case. It appears to be the case now. I'm on a committee with one of the deans from the law school. Apparently dermatology is the specialty of choice because it appears to be a lucrative profession. Next slide. All right, so we still have continuing complaints, even with what we got, and so particularly with people with mental illness, we still have the problem that insurance companies, where they're acting as the gatekeeper, where they're acting as a part of a Medicaid, as part of a managed care plan, whether through Medicaid managed care or private managed care, insurance companies are still twice as likely to deny authorization for mental health care compared to general medicine. There's a limited coverage for brand name antipsychotics, which I talked about before, the formularies. I just mentioned the shortage of mental health providers. The rates are not sufficient to attract them. And that's as a result of the extended waiting list. Then we have this whole problem with the perception that individuals with behavioral health issues are clogging emergency departments. So we'll get to in a moment. I'm not sure if this is a chicken or an egg problem or exactly what this problem is. I'm not sure how real the problem is. We do know that generally that it's a lot more of a problem in South Jersey than North Jersey. And those of you who read who watch the news anymore, there was a thing last week where the governor announced 856 new short-term care psychiatric beds, which is double the size of the psychiatric hospitals. And those of us who have been working for the last 5 years to get people out of psychiatric hospitals were surprised to find that we've just authorized, in essence, 2 new short-term care psychiatric hospitals. So, then the life insurance. So, and then the other, probably the really big problem, the thing that's starting to get people's attention more and more, is the life expectancy of people with mental illness who use the public mental health system is 25 years less than the general population. So if you have a mental illness and you're getting your services, your behavioral health services and your medical health services from the public system, you're still likely to die 25 years sooner than your peers. And you're not dying from mental illness. You're dying from the medical problems. So what are we going to, so that would seem to suggest that people with mental illness are not getting great care or not getting great outcomes from the care that they're receiving. And that's why, next slide. That's why the current discussion is all on integrating behavioral health and primary care. And this is this discussion about making sure that if you're providing behavioral health services, then you've got to pay attention to the person's medical needs, or if you're providing medical health services, you've got to be paying attention to the person's behavioral health needs. And we're having problems. People are trying to work on plans and projects and models that work, and so far we're having problems. The idea is that there's a care team that works together to ensure that there's the relationship. So like we were talking about before, if you go to your primary care provider and he sees that in fact you're diabetic, looks at your medications, if you give him the list of medications and the list is complete and he sees a psychotropic medication on there that may be causing the diabetes, then there's got to be a much larger discussion. There's also problematic that if you're getting, it's also likely that if you're getting psychotropic medication because of mental health needs and you're diabetic, it's probably you're not managing the diabetes very well. So all those things. So instead of it, and as Amy indicated, it's not going to work if you go home and if you tell people as they're walking out the door, here's your diet, make sure you stick to your diet. That's just not going to work. Because among a variety of other things, the individual is not going to have enough money to stick to the diet. Because if you're supposed to be eating fresh fruits and vegetables, you're not going to have money for fresh fruits and vegetables. So there's got to be more to the system. So if you're a solo practitioner or in a small practice, you're not going to have the resources to follow up with that. There's some stuff in the literature where, teaching hospitals in a variety of states have this whole healthcare team that do these miraculous things, and they have these wonderful team meetings. That is just not the way life is for most people who get services. In South Jersey, there's a South Jersey Collaborative that has identified the fact that some small number of people use up the huge amounts of hospital time, emergency department time, and have gone to their 5 hospitals in this consortium in South Jersey. And these individuals have been at all 5 hospitals during the course of a year. One woman had something like 290 days of inpatient hospital care and 89 emergency room visits over the course of 3 or 4 years. So that person cost the hospital several $1 million in services, and they were reimbursed about $800,000. So when they look at these individuals that use a lot of services, the pejorative name frequent flyers. Almost all these individuals have behavioral health diagnoses. But the problem is, if you're running a medical practice, you're just not used to dealing with this population, and your billing codes are not primed to deal with the situation. So if in fact you're a medical healthcare provider, and you're seeing the person for medical care, you may not be authorized to bill for behavioral health codes. So they're just there's the continuing silos, and there are these projects and programs and demonstration grants to do different kinds of projects to create these teams. But as I indicated, there's no culture of collaboration. You still treat behavioral health over here and mental health over here, behavioral health over here and physical health over here. In Jersey, we have so in New Jersey, behavioral health community-based services are regulated by the Department of Human Services. Medical community-based services are regulated by the Department of Health. And for outpatient services, if you want to have behavioral health services and medical services in the same location, New Jersey regulations require separate entrances, separate waiting rooms, and separate restrooms, because there's a concern about mixing the mental health population and the medical population in the same office. Which gets a little silly, because the person who may be in the office on Monday to see the behavioral health, to see the psychiatrist, may be in the office on Tuesday, going through a different door, using a different waiting room and a different restroom for a medical issue that same day. I also happen to think that violates the Americans with Disabilities Act.
So I was going to say, Joe, can't that be litigated?
Yeah, so we're trying to get them. So there's some stuff pending. So at the moment they have, the Department of Health said they're concerned about infectious control. I think it's a smokescreen. So they want, and they want the examination rooms where the people with the medical illnesses are to have washrooms, right? So they do, and the examination rooms for people who are seen for behavioral health issues don't need to have sinks, all right? So they're reluctant to give a waiver to allow co-location if there aren't sinks in all the examining rooms. So they've been giving waivers to some medical care facilities to see people with behavioral health issues, because the sinks already exist in the medical rooms. But there's a hearing. So there's a hearing last week about some of these waivers and trying to do some more integrated healthcare benefits. And representatives from the FQHCs, the federally qualified health centers, who see the poorest of the poor and provide medical services, actually testified that they don't necessarily want to have more people with behavioral health issues provide behavioral health services in their clinics. Which again, in my mind, is a little silly, because they're seeing those populations, they're just seeing them for a different reason. Yeah, so I agree, it's ridiculous. So that's the bureaucratic stuff we got, and that's a holdover from the old days, all right? That's the holdover from mental illness is over here and physical health is over here. And that's why it would be interesting in having some kind of discussion about these people in waiting rooms in the hospitals who are allegedly clogging up the emergency departments. Because my question is so there are a couple of things that we know. So we know that people who did not have insurance knew that they could go to emergency departments for healthcare, right? Because that's where you went if you didn't have any insurance. You know you could go there. It's the worst place to go for a variety of reasons. It's the most expensive place to go. But if you needed a service, you needed to go there. So my concern about emergency departments and claiming that the people with mental illness are clogging the emergency departments is that some of these statistics don't differentiate why the person is in the emergency department. Excuse me. Are they there for a mental health reason, or are they there for a behavioral health reason? Do they present as having a mental illness when they're really there because they have a medical issue? And my experience with emergency departments is the interview is very short and the tests are very long. So there isn't a great effort when you present yourself at an emergency department to ferret out what the real disability, what the real cause of the presentation may be. I know that I've been representing people with mental illness for a very, very long time now. And I have had many interview with an individual where I didn't find out until minute 30 or minute 45 what the real issue was. And we do know, clearly, we know that people with mental illness, even people with delusions, aren't delusional about everything, and can present legitimate concerns and complaints about a variety of things. So we had, unfortunately, experienced a long time ago about somebody who kept coming into our office and complained that somebody was focusing a beam at his head. And we considered it delusional and all that kind of stuff. He actually died of a brain tumor, which nobody diagnosed to the end. So because everybody took this delusion as his illness and didn't make any effort to drill down to see if something else was actually going on. So that's one of my concerns about saying all these people are in the emergency departments and they need to be in healthcare about whether or not how those distinctions are being made and what's the effort to really drill down and diagnose what a person's presenting thing is. And we also know that even while people may now have insurance and can go to other places, it's a culture shift. If you're used to going to the emergency room for your primary health care services, even if you have insurance and can go someplace else, it's going to take a generation or two before that becomes the norm. You're going to actually have to help people figure out and take them someplace they like, and have them appreciate that there are other places beside the emergency room that they can go. So rather than just treating, a good social worker and a good psychiatric advanced practices nurse in an emergency room would be a really big boon to a lot of emergency departments, in my humble opinion. All right. So there have been a number of suggestions by a number of people about how do we improve healthcare outcomes for people with behavioral health issues. And you're going to look at my list and back one.
Sorry.
No problem. If you look at this list, this should look very familiar to anybody who's doing psych rehab, because a lot of this is what I believe should be going on with good psych rehab programs and people who are helping people into wellness and recovery. You want to empower individuals with authority, access, and educational tools that assist the individual with helping to make their own decisions. So you've got to give them the information, but also that when they make the decision, then you have to follow the decision. You have to empower them and say, you need to make this decision. We're giving you the information to make the decision. We will help you through the decision. Now, when shared decision making is down here, the decision doesn't always have to be the right decision. So part of the role then is, if the decision is a wrong decision, like I'm going to go out, I'm going to go to McDonald's every day, I'm not going to pay attention to the fruit and vegetables thing. There's got to be a mechanism there that we're going to double check how that decision is working. All right. They got, and so if it's not working, if the diabetes is not under control, if the glucose numbers are worse than they were before, then we go back and make the decision again. So this is the first two things go together. You give them the access, authority, and educational tools, and then you engage and you use shared and supported decision making in helping people make those decisions, and then get the information so that you can determine whether these decisions are working and how to modify the decisions that people are making. So I've used the term supported decision making. I don't know if that's made it into psych rehab yet. It's the new legal preferred term. Shared decision making is a medical term. For the most part, shared decision making is what doctors talk about when they allow patients to have an opinion. Supported decision making is across the board kind of thing. There are 10 steps to supported decision making, but it's all pretty much the same kind of thing. You give the person information, you tell them they have a decision to make, you figure out how they like to make decisions, you figure out how they'd like to get input for the decisions, and then you help them make the decision to the extent that they're able to make the decision. So it's not just presenting them with a decision and allowing them to have an opinion, it's giving them the tools to make the decision.
Joe, it's Amy again. I'm sorry to jump in on this, but so I haven't really read a lot about supported decision making or the 10 steps that you're describing. But what our students may have been exposed to and what we've looked at is the model that Pat Deegan kind of developed and then designed a website actually around, which is the personalized medicine approach. Have you heard about this one?
That one I haven't heard of.
So it sounds like very similar to what you're saying, in that people plan ahead of the discussions with their healthcare provider. They go prepared to those initial screenings and assessment appointments, and they can include an advocate or supporter to be with them to kind of help record information or remind them of questions they may have forgotten. And then they work with whatever natural supports they have in place to kind of fulfill the treatment strategy. Does that sound similar?
It sounds very similar and just a teeny bit different. All right. So so supported decision. First of all, there is a website. I'll give you a website. It's supporteddecisionmaking.org. No. So here's what I'm. So if you Google shared decision making, in response to the question I saw at the bottom, if you Google shared decision making, you're going to see a lot of YouTube videos explaining to doctors what shared decision making is. Supported decision making can be used in any circumstance. All right. So what Amy just described sounds like an excellent idea, and people should be doing that. Anybody should be doing it for themselves, and usually don't. But prepare you for a doctor's visit. Supported decision making is applicable to any decision somebody with a limited capacity, somebody who's perceived to have a limited capacity, would be helpful with. So it started primarily with people with intellectual disabilities. It's what a number of us who work with the disability rights movement are touting instead of guardianship these days. So in my mind, it would be very applicable to the community supports program or CSS. So when a peer or a worker is working with somebody in the CSS program, and the issue is, the landlord's getting upset because you're making too much noise at night, that's a mechanism for engaging in supported decision making. So we have a problem. The landlord doesn't like you making too much noise at night. We have to make a decision, because if this continues on, you're going to be evicted. So we have to make a decision. So how are we going to deal with this problem about too much noise at night? So I like to have noise at night because I like I like my friends to come over. So then we have a discussion about, are there other ways can we have other times? Can you visit your friends someplace else? So it just goes through, it helps somebody to make decisions in whatever range it may be, whatever activity it may be, to help. And we all know that the more that you engage, you allow somebody to make their own decisions, the more capable they become in making decisions, whole variety of things like that. So supported decision making is just a new way of a way that the lawyers, because there are a couple court cases now which say that instead of a guardianship, a person can have a supported decision making arrangement, so that the guardian is no longer the decision maker, the person still is, with the supports built around them. So it's the supportive housing analog to decision making. All right. Anytime. So hopefully that helps. But these are so you support decision-making, behavioral changes such as quitting smoking. So again, it's not just telling somebody they need to do this. It's helping them through the process and encouraging them. And again, as I indicate, promoting wellness and recovery, self-management programs, RAP, and other recovery programs. All these things, in addition to, so to some extent, so these are empowering people to make their own decisions in healthcare. And through that, then, I guess there's some hope that when you go to the doctor and you see that your diabetes numbers are not going down, and you're doing what you can, then you start asking the doctor questions about how do I deal with this? Or I can't stop eating this because I get too depressed at night, or some other simplistic thing that hypothetical. I mean, so that you then bring this discussion to the doctor through that process that you talked about. Was it personal health decisions or personal health planning?
Personal medicine.
Yeah. So you help the individual recognize the things that they need to talk to other people about. All right. Now we can go to the brave new world of who knows what the blazes is going to happen. So when we hear discussions about repealing and replacing the ACA, the most thing that we hear about is Medicaid. And I hope that I was clear enough through the discussion that I indicated that the changes to Medicaid, the Medicaid expansion, the services that are available through Medicaid, and the number of people with mental illness and substance abuse that are covered through Medicaid, that any change to Medicaid is going to seriously affect our population. There are a variety of nonsense things that they're talking about. The block granting thing creates a problem. I know our governor thinks that block granting would be a good idea. Just give me the money that I'm getting and let me decide who gets services and who doesn't get services. So we know if he gets to do that, there's going to be a lot more money for substance abuse, which would be a good thing. But someone's going to lose money. And it's also very likely if block granting comes to the states, it's going to come with a number. It's going to come with a number that the states are not going to be able to go over. So at the moment, the way the Medicaid works if 100,000 more people use a service this year, meant that the feds will come up with their share of that money. Now, hopefully the states will come up with their share of the money, but the feds will come up with their share of the money. Under a block grant system, if there's a cap, and the feds say New Jersey gets $1 billion in Medicaid services, that's all New Jersey's getting, even though they may bill $2 billion or have legitimate costs that would cost $2 billion, they're only get $1 billion. And so the state is going to have to pick up or reduce services. And that's the concern everybody has about block granting. In addition to the fact that there's a concern that, again, mental health is still viewed as that illness in the corner that nobody else wants to deal with. And I think something I read this morning, that there's as much money spent on mental health services as there is on cancer treatment. And I went to the Rutgers women's basketball game last night, and the whole halftime was devoting to celebrating breast cancer survivors, a very laudable event. But at no halftime does everybody celebrate people with mental illness. It's not going to get the money or the attention that the other illnesses are going to get, the other conditions are going to get. So there's going to be a real risk to our population with block granting and caps on services. Eliminating and reducing Medicaid expansion is something that's been talked about. I think everybody agrees that that's going to be a real risky thing. There are 38 states that are getting help through the feds to pay for this population that otherwise would be very expensive to deal with. So the belief is that that's going to be very hard to get the states, even the Republican states, to go along with reducing or eliminating the Medicaid expansion population, which has brought in something like 12 million more people into 7 million, between 12 and 7 million more people into health services. The other thing that they're talking about sounds an awful lot like welfare reform again. So unfortunately during the Clinton administration, there was idea that people are on welfare because they want to be, or because it's easy for them to stay on there. So all the other discussions about reducing Medicaid is this idea that people are on Medicaid because they want to be, and that we're going to do these things to make sure that people get off who are not deserving enough to get Medicaid services. So one thing would be to eliminate the navigators, so to make it more difficult for people to figure out how to get services. Limit enrollment periods so that you can only get on Medicaid during the open enrollment periods. Now you can get on if there's a change in your healthcare thing and you need the Medicaid, you get on it anytime during the year. You can't change plans except during open enrollment periods, but you can get on. One plan is that so you only can join Medicaid from November to December. You have an illness in February last year, tough, you're gonna have to figure out what to do about that. Contributions to premiums and copays for Medicaid is another thing that's come up with. Jersey has attempted once or twice to have people who are receiving Medicaid in New Jersey to have copays for prescriptions. And again, for our population, that becomes more problematic than most, because a lot of the mental health medications, you don't get a 30 or 90-day supply. You get a 1 week or 2 week supply, so you have to go back to the doctor to get another prescription. So if you have to pay a copay and a prescription, every time you have to go back and get another prescription, you're going to pay more copays than people with mental illness. And don't forget, you're on Medicaid. If you're on Medicaid with SSI and you're getting $770 a month and your rent is $660 a month, there's not a whole extra $2, $3, $5 around there to pay for copays. Again, they're bringing up this requirement. You can't, if you're going to be on Medicaid, you have to try to work. I thought we debunked that idea a long time ago, but apparently not. And then the other ones that we just kind of talked about, right, you want to get on Medicaid and you got this diabetes problem, then you're going to have to follow a diet. You don't follow the diet, you're not going to get Medicaid anymore. The big problem for our population if they try to enforce those kinds of things. I think that's my last slide.
Joe.
Oh, I'm sorry.
Can you go back to that slide, Derek?
Yeah.
I am concerned about all these things, but none of these things have been enacted.
No. These are all, so we have absolutely no idea what's going to happen with repeal and replace.
Right.
Or
right.
repeal and modify, or repeal and whatever.
It looks more and more like it's going to be less of a change than they were,
right.
Than they were, right. So they're realizing that if they do a lot of these things, that they're going to get so much, resistance.
Right.
It's not going to be worth it.
Right. So a lot of things that people like, the 26, the coverage up to 26 years, the no pre-existing conditions, to some extent the essential health benefits. People won't believe that's part of the Affordable Care Act and not part of Obamacare. Obamacare is the bad part,
right?
Whatever that is.
We agree on that.
Right. So the good part is the Affordable Care Act. We want to keep that. So the thing that everybody says, I'm not sure what's on my next. These are things that have been discussed. These are things that have been that were floated before the administration came in, by some of the think tank things that be coming along. So because
I think calling them think tanks are being very generous.
Yes. That's something else we can agree on. So I'm not sure what's on my next slide at the moment because I can't remember whether I get to this or not. So this is, so clearly I've already said this. If you reduce the access to Medicaid, there are going to be more people going to the emergency room. We're going to go right back to where we were before. There are going to be increased charity care costs, and there's going to be a decrease in positive outcome. You decrease access to services, you're going to decrease the positive outcomes. Is that my last slide?
Sure is.
Yes. All right. So go back to the two before that, if you could, Derek. I appreciate it. Yeah. The one thing that's not on here, the thing that is more likely, is some version of what Speaker Ryan has been talking about, and that's eliminating the exchanges or reducing reliance on the exchanges and going back more to private health insurance. Giving people, instead of making, instead of having people, giving people tax subsidies to purchase insurance plans. So if you don't pay taxes in the first place because you don't have enough income, I'm not sure how a tax subsidy helps you purchase anything. And you're still going to have to bring insurance companies into the market. And you're not going to bring insurance companies into the market unless you have almost universal coverage. Because the insurance companies have to have well people as well as sick people to make a go of things, or to have government guaranteed to cover their losses. So without something like that, I'm not sure how it works. And as I said before, the other problem with so your employer, instead of covering you in your insurance plan, will give you X amount of money in your health savings account to allow you to purchase an insurance plan. So we all know that the tendency is going to be for people to purchase those high deductible plans, that kick in once you have $10,000 worth of expenses in a year. That's not going to work for people with chronic illnesses. So a lot of these plans, a lot of these ideas are good for people who are well, but not so good for people who are going to be ill. So it's really not clear what the repair and replace is about. I think Carlos is right, that they're going to be tinkering around the edges, and they'll come up with some example of somebody who somehow got what they weren't supposed to get, or that Medicaid's paying for gender reassignment surgery, which now all of a sudden is going to be a horrible thing, and therefore we have to replace stuff. There'll be some bizarre issue that policy will be made on without thinking through consequences at some point. The worst possible scenario, which I hope they're getting away from, is repeal and we'll figure out what we're going to replace with later, because clearly that's not going to work. They've done that a couple of times. That's why we still have sequestration. That's why we're looking at 20% cuts in funding for non-defense discretionary things this year, because they said we're going to have these horrible cuts, and because these cuts are so horrible, we'll come up with a different scheme to take care of the cuts, and then they didn't. So at the moment, what we can say is, in summary, is that the Affordable Care Act has put some stuff in place that has been a big boon to people with chronic mental illness. There is still a problem in that the system is expensive. There are still waits for services, and the health outcomes are not as good as they should be. So we're getting access to services. Question is, are we getting access to the right services and the quality of services that people need in order to get good healthcare outcomes? The proposed solution to that is integrated healthcare, where behavioral health is treated as behavioral health and medical health are considered the same thing. That get responded to in the same way and have comparable resources applied to them, and that the delivery of healthcare services is a unified thing, where healthcare services are identified, whether they be behavioral healthcare or medical healthcare, by the primary care provider or the team that surrounds the primary care provider. That's going to be a very difficult thing to accomplish. And while there are programs that have great success, those are programs at the moment have a lot of resources. And so I think that is the extent of my limited knowledge on operations. And be happy any other questions people may have.
Joe, I'm going to ask that you just lower your computer volume a tiny
Absolutely.
bit, because if you are too loud, everyone else will get that bounce back.
No problem.
Okay. Well, firstly, limited is not at all how I would describe your conversation with us today. I've learned every time I listen to you talk, I learn something else, and I appreciate that very much. We've been reviewing the article you sent us to look at, and we had posted a lecture that Derek and I worked on last year on the ACA that gave a lot of background information, but certainly didn't address at all kind of the state of affairs that we're experiencing right now, both with fee for service in New Jersey, as well as the potential repeal or replace or modify of the ACA. So this fits really nicely into what we're talking about in class, and also New Jersey and on a national level. So I hesitate to ask this question because I think you've been very, very clear in describing it already, but I want to put it out there because it was a question I prepared for you before hearing your lecture, and I want to just confirm. So what emerging policy or policies do you think will have the most significant impact on the delivery of mental health services in New Jersey?
Right. So I think it's what I recently said. So it's got to be, we know that people who have chronic mental illness are poor. So there's got to be a healthcare system that provides insurance for people who cannot afford insurance on their own. So in New Jersey at the moment, New Jersey's Medicaid system, the services that are available in New Jersey through the Medicaid program, is as good as any other state. So we have, in New Jersey in Medicaid, we have every possible mandatory and optional service there can be. So if you're able to access Medicaid, you can or should be able to access the full variety of services that are available through Medicaid. And if you're poor, that's going to be the way to access services. The problem that we have with that system is you're not always reimbursing the providers. Our Medicaid rates are generally not very good. No states' Medicaid rates are very good. So it may not attract enough people, enough providers to provide a full amount of services and to eliminate waiting lists. So access to healthcare is clearly one, and then the integrated healthcare, I think, is increasingly important. That we're going to have to come up with ways to ensure that people who are providing treatment to people with chronic mental illness and chronic medical conditions see the whole person and not just the half of the person that they're treating. And those programs have to be incentivized. There's got to be a way of encouraging people to do that.
Thanks. So I want to open it up to the group, including Derek and Carlos, if there are any other questions related to what you covered. And then I have another question or two, more general, not necessarily specific to the ACA, even though I love you love talking about it so much. So class, you guys should have full control over your own microphone. And if you would like to unmute and ask a question, I encourage you to do that. And Carlos and Derek, that applies to you as well.
I had one question. Doesn't really relate to the population, but just like speculating. Do you think that there's a potential that the new administration does something to sort of replace Obamacare with sort of like a public Medicaid option where anyone could buy in? And the services would be kind of comparable to Medicaid, but still offer something as an alternative to the people that would potentially become uninsured in the repeal process?
Yeah. So the answer to your question is no, because so the brief history of the Affordable Care Act is that, to make it very, very simple, all right. The single payer system, which is what we were talking about having everybody on Medicare, essentially, would be a Democratic plan. It was clearly what Bernie Sanders was promoting during his campaign. The reason that we have the system that we have now, which is a mix of public and private benefits, is it was actually originally a Republican plan. And the president promoted it in the hopes that he would get some Republicans to buy into it. The Democrats, or a large segment of Democrats then, and there's a large segment now, that would prefer the single payer system. And there's an article, I think, in this week's or last week's journal, New England Journal of Medicine, about 50% of the physicians would prefer a single payer system. The other 50% would prefer a private system. So we have absolutely no agreement in this country about that system at the moment. So the new administration is not going to walk anywhere near a single payer government oriented system. If there's a replacement, and if Bernie Sanders and the millennials take over, then there's much more likelihood of that kind of system going in. But there's some, like every other country in the world, I mean, almost every other country in the world has basically a single payer. All the developed countries have a single payer government sponsored system for the most part. We're still in this private mix.
Thanks.
Right.
Anybody else have questions for Joe? Carlos, if you don't mind, I'm going to put you on the spot. And if you do mind, I apologize, but it's too late. So in a conversation, Joe, that Carlos and I had earlier today, I had shared a kind of rambling, but I think still interesting piece written. It was more like an op-ed written about what are all the potential horrible things that could happen if the ACA is repealed. And as Carlos pointed out to you just a few minutes ago, it seems likely that changes will not be very significant in all areas that people are worried about. And Carlos made a point that I wanted him to give to you and say much more articulately than I can, about his concern that if we are so narrow-minded and so anti the current administration, positive edits, for lack of better words, will be just opposed because of who's proposing them. So, Carlos, can you say that better?
Yeah, because I don't think that's what I said.
Oh, good.
No, my concern was more of a strategic concern, and it doesn't necessarily deal only with the ACA. It deals with, and I use the example of the Women's March as compared to the demonstrations when the travel ban went in. And I thought the Women's March, which was, everybody got very involved in, but it was somewhat undirected, and it was based on some assumptions about what might happen. And I'm afraid of those kinds of demonstrations because I think they dissipate activism, whereas the responses to the ban were real in the sense that they were responding to an actual act of the administration. And I'm just concerned that we not spend a great deal of energy on things that haven't happened yet. So it's it's not about the ACA, it's just a general strategy question about how to oppose, there's some parts of this administration that we feel might hurt us.
Right. So that's something that would be a wonderful thing to have a very long discussion about.
Right.
Because first of all, in this particular situation, when we're talking about repeal and replace, and so those are words the president has used, but the president has also said it's that Obamacare, that's the bad part. Obamacare is going to be replaced by something better and cheaper.
Right.
So everybody's still going to have insurance, and it's going to cost everybody less money than it's costing now.
And it's going to be better.
Yeah. So right. So who can oppose that? So if you, and that particular strategy is a divide and conquer strategy. If your goal is to in fact have as good a healthcare system as we have now, and having what we have improved rather than destroyed, then you talk to the people in Congress that the president wants better and cheaper. more people covered and costing everybody less. Heaven knows how that's going to happen, but that's what he said. So you can't disagree with him on that at all. Where I would disagree with you sometimes is a strategy that I sometimes have used as an attorney, and that it's a kind of a preemptive strike kind of situation.
Mhm.
So a perfect example one time was that in the old days, we had a thing in the New Jersey Constitution that said that the insane and imbeciles were not allowed to vote. So there was a challenge in a municipal election against 3 or 4 people that lived in a group home in one municipality, so that the council race in that ward was like 2 votes. So the person that lost was challenging the votes of these people in lived in a group home with intellectual disabilities. And so before the hearing even started, I went up to the person and I said, well, the Constitution says only the insane and imbeciles can't vote. Certainly hope you're not going to claim that my clients are either insane or imbeciles. So he didn't. So that was a kind of a preemptive strike kind of thing.
Mhm.
So to the extent that the Women's March was, you better keep your hands off women's issues, or women, as the case may be, then that may make it more difficult to bring up the issue in the future. But I agree. Otherwise, you just can't. I mean, people were opposing stuff because the administration. A number of people were opposing stuff just because the administration did it without thinking through the process.
Right.
So there was a lot of hysteria last week about people with mental illness getting guns. Well, and that the Republicans were giving people with mental illness guns. That wasn't the issue. We were on the side of that ended up being the side that the Republicans were on and the Democrats were not on, and Rachel Maddow was not on. So our organization was on the other side, because what it was the Obama administration had proposed a regulation which said that if you had a representative payee, then you should be in the you can't buy a gun list. In our argument, I mean, so again, that was stigmatizing people with disabilities as opposed to looking at the real issue.
Right.
So there's nothing about having a representative payee which has any direct correlation with the capacity to own a gun. My views on gun ownership aside. So we were in a unique position at that time of taking that kind of position, which immediately got interpreted, we're giving everybody with mental illness a gun, which was not the issue.
Right.
You got to be careful about deciding that or saying everything that's happening there is wrong. Pick and choose the issues that are important. In for the healthcare thing, I think you lay out some stuff. I think you can approach people in Congress, particularly some Republicans in New Jersey who are in positions of power and may be willing to listen to some stuff about how important some of these issues are. Representative Frelinghuysen is in a very powerful position at the moment. He's been a champion of it, people with mental health issues in the past. Impressing upon him the importance of maintaining these things, I think, would be very helpful.
I agree. Yeah.
Thanks, Joe.
Sure.
I have only one last question, but it's somewhat of a 2-part question. So the first is, if you had to describe what the mission of Disability Rights New Jersey is, what would you say? And what is the most exciting thing you folks are engaged in right now?
Exciting is trying to stay alive at this point. So we protect the civil and legal rights of individuals with disabilities. That's our mission. Actually, I have a brochure right here, advocating and advancing the legal and civil rights of individuals, of persons with disabilities. So there we go, the brochure. Which, if I would have been invited to Scotch Plains, I would have brought along with me.
I'm gonna put a link to the site in our web post, Joe.
That's fine. We're part of a nationwide system of protection and advocacy programs, which was established in the 1970s when Geraldo Rivera was still a legitimate journalist and did the expose of the Willowbrook School in Staten Island. So he went into what was then an institution for people with mental retardation and exposed how horrible the conditions were in that institution. So Congress at the time decided that maybe the states were not treating people with disabilities well. And so maybe there should be an oversight agency in every state that monitors how the state treats people with disabilities. So that's been our role since the 70s. Disability Rights New Jersey was part of the state government until 1994. We were in the role of the Protection Advocacy Program was in the Department of the Public Advocate. It was privatized in 1994. We changed our name in 2008 to Disability Rights New Jersey. About at least half the other states are agencies similar to us, have similar names. Excuse me. So there's Disability Rights New York, Disability Rights Washington, Disability Rights North Carolina, Disability Rights California. So if you're looking for a program similar, I'd start off with Disability Rights. Alabama has a different name because it's Alabama. But so we go in. So one of the roles is to go into institutions. We go into psych hospitals, developmental centers, nursing homes to make sure people are not subject to abuse and neglect in those places. We help to try and enforce the Americans with Disabilities Act and the New Jersey Law Against Discrimination. We do a lot of special ed cases, which apparently we're not going to have to do anymore if the federal government eliminates education for kids with disabilities. That's kind of a facetious thing, but yesterday the Department of Education's website for students with disabilities disappeared. And we do a lot of vocational rehab work, assisting people who are trying to get rehab services from the state government. So we act as the attorney for people with disabilities when their issue is a disability. And we don't charge a fee for our services yet. All our funding runs out on April 28th, depending on what Congress does. So that's why talking about staying alive is there. All the funding for the federal government runs out on April 28th. So at some point, somebody's got to come up with a plan for what they're going to do for the next 200 years. And the excitement at the moment, I guess the frustration at the moment is trying to deal with the transition to fee-for-services for both mental health and developmental disabilities. And then, as always, the psych hospitals are a source of amusement. Ancora Psychiatric Hospital has recently said that families, members, and patients cannot bring in clothing from the outside. You can only wear or buy clothing at their company store. You can only possess possessions that are bought at their company store, which sounds like a return to, I don't know what, the Middle Ages of some kind. So we're trying to knock them over the head and trying to get some sense into them about, they're not running they're not running a dungeon or a medieval institution. It's supposed to be a wellness recovery related healthcare program. So that's one of the things we're having fun with right now.
Thanks. I hadn't heard that about the company store, which I think is a funny way to call it.
That's obviously I'm calling it that for a reason, right? You get to put your own label on things. You control the discussion. So, so there was a very good. So during the campaign that we just went through, there was a guy who was a Republican strategist, and his whole what he did, he got paid to change labels on things, and that changed the discussion. So so there used to be this thing called the estate tax. When somebody died, the state, the government, feds and local government, state government, generally took a share of the estate and then redistributed it. Well, he's the one that came up with the idea of labeling it a death tax. So now everybody thinks that, well, it was a horrible thing. When it was an estate tax, it was a good social thing to do. Now that it's a death tax, everybody's opposed to it. So you get to put labels on things, you get to control the discussion. So that's
we learned from the Republicans.
Yeah. All right. Thanks. Any other questions for Joe? So Joe, we're gonna talk about some of these issues when we get together live in the classroom, because we like to do kind of a follow-up to these discussions. So if there are questions that are asked of Derek and I that we are certainly not able to answer, would it be okay if we reached out to you?
Oh, by all means. You have my email address anytime.
Yeah, I'm going to put the Disability Rights New Jersey website up on our Moodle course page. Our students have read through the assigned reading that you suggested, and we'll make that part of our discussion next week. And I can't thank you enough for taking the time on this snowy day to sit with us and share your thoughts. It's really
happy to do it. And so this is actually the second time within a week I've used Zoom.
Is it?
Yeah, we used it for, we have an advisory committee, actually our assistive technology advisory committee. So they decided we needed to use assistive technology or high-end technology for our meetings. So
Cool.
So I'm becoming very familiar now with the program.
Good. Well, if you're ever bored on a Thursday and you'd like us to Zoom you in, we meet every week. So thank you so much. And class, thanks for joining in today. I know it was short notice and you all jumped on board, and I appreciate that. And we'll see you next week.
Thanks a lot.
Thank you.
Thanks, Joe. Wonderful.
Thanks. Take care.
Bye.
Take care.
Bye-bye.
Bye.